Dear Liliana, colleagues and friends, SARS-CoV-2 has hit this world at the end of last year and spread since then from China throughout this world. And there's hardly any part in the world which has not been hit hard by it. I've never experienced this before. In these last months, we have sadly learned a lot about the effect globalization has on spreading of infectious diseases, the effect of the official politics in regard to health threats, the effect of long-term political willingness to provide a strong healthcare system or not, and about thousands of individuals who stepped in to help. Too many doctors and nurses paid this with their own life because the healthcare system didn't provide a sufficient protection. I'm not the expert on this, but I'm happy to share my thoughts, thinking of you in this challenging time. While the numbers of the daily infected and diseased people was truly overwhelming and did temporarily overwhelm the healthcare in Italy, Spain, France, and other parts of the world, the daily news itself became overwhelming. All news channels reported only on the progress of the virus throughout this world, and checking the daily losses must feel similar to war times. Everywhere, experts and prophets appeared knowing and announcing already the unknown and predicting different horror scenarios. It was hard to find orientation in this jungle of opinions, how much more so if you as the head of the state had to take decisions for a whole country. I hope we will take the time to learn when looking back. What have we learned? Fortunately, for the most people, the infection with SARS-CoV-2 is not much more than a common cold. As you can see on the left side, classic symptoms appearing, and many of you probably saw these in your patients or may have experienced them yourself. But the fear was spreading in the absence of reliable tests and the knowledge that asymptomatic people could transfer a disease, which in about 15% of patients develops into a severe, and in some patients into a potentially life-threatening systemic inflammatory multi-organ disease, of which the acute respiratory distress syndrome is only the tip of the iceberg. And we learned a lot lately about other organs being involved, and you see them listed on the right hand of this slide. Besides high viral loads at the time of infection and potentially strain variants, host factors associated with a severe disease, manifesting often with the typical infiltrates shown in the upper right of the slide, include high age, male gender, cardiovascular disease, diabetes, obesity, and possibly lung disease. And relevant for our patients, certain immune disorders were suspected. While everyone was advised to lock down during the fast-spreading pandemic, stratifying our patients in normal and high-risk groups has become more and more important, especially in the phase we are currently entering in Germany and many other parts in the world, when the restrictions are partly released and we need to advise our patients whether they need to be extra careful or can slowly return to normal life as the rest of the population, since the continuation of the lockdown is associated with a high price for everyone. As I will show on the next slide, many of our patients can probably be advised like the normal population, according to the general risk factors mentioned before. Fortunately, so far there are very few reports on patients with primary immunodeficiency published. And in our cohort, we had 3 patients. 2 patients with common variable immunodeficiency, one 60-year-old woman who suffered only briefly from symptoms of a common cold and was fine, and a 60-year-old man with common variable immunodeficiency who suffered from a prolonged period of fever of 6 weeks and then recovered. The 3rd patient with a combined immunodeficiency of unknown origin and recurrent inflammatory phases had the most severe course. When he became oxygen dependent under high fever, we treated him with tocilizumab. He recovered and was never on the ICU. All patients are now fine and at home. One additional message from our patients is that all of them had positive virus swabs for over 6 weeks, even after clinical recovery. Therefore, primary immunodeficiency patients may spread virus much longer than other people, and this needs to be addressed in the follow-up of our patients. In talking to my patients and the other patients, these stories have become helpful in reassuring that suffering from primary immunodeficiency or common variable immunodeficiency, as has been suggested by the Italian cohort, is not necessarily associated with a severe course of the disease. We are still lacking good data to advise our patients precisely. But as in many countries, the lockdown is increasingly reversed, we need to give our patients answers to the questions. Who can go back to school? Who can go back to work? Or live in the same household with people who are potentially exposed to COVID-19? I have listed at the bottom a few sites with helpful information on COVID-19 for primary immunodeficiency patients. And I congratulate you to your information on the LASIT website. And very important, please register all your patients with COVID-19 in COPIT, as you see at the bottom, so that we can all learn from one another. Touching treatment strategies, which have developed during the last 2 months. On the one side, we need effective antiviral drugs. And on the other hand, we need immunological treatment strategies to control the severe disease, or even better, prevent the severe disease. It is developing by blocking the virus, as has been suggested on the left lower side, you can see here, or removing or blocking pro-inflammatory cytokines. And hopefully vaccination will help starting 2021 to control the pandemic by inducing neutralizing antibodies and effective T-cell responses in vaccinated people. The mentioned article gives also an overview about the current hypothesis of the pathogenesis of the systemic disease associated with COVID-19. As the general press, also the medical press has produced an overwhelming amount of articles in short time, making it difficult to distinguish between urgently longed for fast results, which didn't hold true in the long run, however, and well-founded results and recommendations. Therefore, the literature needs to be read very carefully at this time. Over 12,000 hits are found in PubMed as of today for COVID-19, and over 3,500 in regard to its treatment. We all wanted to know fast, so many case reports have been published, but we were not able to produce higher quality clinical trials within this short period. Many of them are running now and hopefully will give us helpful insights in the future. But we're not able to produce the results during the heat of the pandemic. We can currently safely say that lopinavir, ritonavir is not helpful and put some of our patients even at risk of side effects. Also, hydroxychloroquine or chloroquine has not fulfilled the initial expectation, although a minor effect is still possible. Currently, the biggest hope is on the antiviral drug remdesivir, and hopefully the results of controlled trials will soon be available and allow a broader treatment and access to treatment for affected patients. It will be seen whether combination therapy is more powerful, as in many other viral diseases. Based on some experience in SARS-1 and some case reports, treatment with reconvalescent plasma will hopefully shorten the course of the disease, although a discussion is ongoing whether giving at the wrong time the plasma may exacerbate lung or other organ inflammation. I have no personal experience with it. For our patients on immunoglobulin replacement therapy, it will be of high interest to have IgG preparations enriched for neutralizing anti-spike antibodies. In order to control hyperinflammation in the severe patients, my feeling is that tocilizumab can do a good job, especially when given at the rise of inflammation. Anakinra, as mentioned at the bottom, may be able to do so as well, although we had given it to one of our patients without effect on the fever. Here, the laboratory parameters of inflammation, as in CRP, IL-6, ferritin, may be foretelling potential response to our drug treatment. Sadly, we have seen and read that many of the people of the medical teams were infected and succumbed to the disease in many countries. partly due to the poor equipment provided in areas of high exposure. Having talked to colleagues in Italy and seeing the pictures of triaging patients because of the large amounts of patients coming into the emergency, I felt that this article on how to lead your team in this challenging time was very timely and appropriate. It is amazing what these teams all over the world were able to accomplish. So be careful as you work. Be encouraging not only to your patients, but also to your colleagues, to your boss, your employees, nurses, and doctors. It has become more and more crucial that we discuss with our patients how the virus spreads and how to protect themselves. It is important that we address these points in times of many news, either falsely exaggerating or downplaying the risk and ways of infection. We need to be fully aware and listen to the personal situation of our patients in order to give them reasonable advice on social distancing, on masks and wearing masks, and on hand disinfection. So this becomes important as the initial fear has been replaced by more and more complacency. And so please talk to your patients so that you know where they are at, that you inform them and help them to have the best advice they can have in this jungle of information. It is a time which has revealed a lot about us. We saw the fear depleting disinfectants and toilet paper worldwide. But with time, we also saw the creative ways men and women responded and moved closer in their support, still keeping the rules of social distancing. The many food services, famous people and unknown choirs singing online, bringing culture into our homes. It was touching and encouraging at the same time to see. I would like to close with a statement of the Pope, which I think is touching, whether you believe in the Christian faith or not. It is the hope looking forward to the time when normality will seem like a gift, when we can hug each other and enjoy the beauty of the moment close to each other again. The photos you can see here are images of great memories I have from my times with you, and I'm looking forward to new times with you again. I wish you all the best. Be safe and be encouraged. Love, Klaus.